everybody, it's a great pleasure to be back with you again after such a long hiatus, and I apologize for that. We'll try to be more diligent in the future, and I'm going to do my very best to put out these types of videos on a more frequent and regular basis from here on out. I just wanted to let you know that as I'm moving more and more towards the third act of this professional play called life, my plan is to do more and more consultations on complicated cases, people that are spinning their wheels. In fact, my practice is largely consumed by people who've done IVF repeatedly and not been successful, or women that are older and unable to get pregnant, or people that have had repeated pregnancy losses or miscarriages. So that'll be my emphasis in future, to try to spend as much time as I can putting 37 years of experience into giving you the best possible advice possible. Excuse me. Today's topic is extremely important, one that I feel is something we should talk about at some length. You know, hardly a day goes by that I don't talk to someone who says to me, I've been trying IVF and I've done it over and over and I've not gotten pregnant. What could the possible reason be? Why am I not getting pregnant with IVF? And that is something that I want to delve into today a little bit. Firstly, I want to make it very, very clear that there is an element of luck involved in IVF, no matter what you do. It's true that in most cases you're never going to get pregnant more than 50% of the time that you try, even under the best circumstances. One transfer of embryos at best is going to give you a 40 to 50% chance of a baby if you're young and you have good quality embryos. And with two transfers, it should be up in the 70 to 80% chance, provided there isn't a factor underlying that repeatedly causes the failure. So we're going to be dealing with this issue today. I'd also like to point out that IVF failure can be due to a multiplicity of causes besides bad luck. There are factors that set you up for failure, and if they're not identified, quantified and typified up front, they will not be addressed and you'll keep on spinning your wheels. Many such patients, the very ones that end up with me. So let's talk about these factors and see what they involve. Firstly, before I start, let me just say this. We have a new tool for the last 15 years in the field where we can identify the quality of a woman's embryos by doing genetic or chromosomal testing on the embryos. We call it PGT or PGS. That's where we do pre-implantation genetic screening or pre-implantation genetic testing to count the number of chromosomes in the cells of the embryo. If the number of chromosomes are regular, and that is there is at least 46 chromosomes, shouldn't be at least. There must be 46 chromosomes, no more and no less. If the embryo contains more than or less than 46 chromosomes, it's referred to as being aneuploid. Such embryos are incompetent, and upon being transferred will either not attach, will attach very briefly and miscarry, or if a calamity strikes, will go on to propagate a baby with a serious chromosomal defect, like Down syndrome or Edwards syndrome. The former is where there's an extra chromosome in position 21, and the latter where there's an extra chromosome position 18. There are others as well, but those are the common ones that cause the problems. Such women will more often than not even know they were pregnant. They lose the pregnancy so early because of the chromosomal aneuploidy. And they'll think they're infertile when, as in reality, they're having many miscarriages. So today, before we go any further, let me just make it clear that if women are having repeated IVF failures for whatever reason, it's very important to test the embryo through PGT or PGS to make sure that there are exactly 46 chromosomes present. Also important to know that in certain circumstances, an extra chromosome or two, or too few chromosomes by one or two, can still be compatible with a viable embryo. That happens when some of the cells of the embryo are abnormal, and when removed by biopsy are found to be aneuploid, whereas the majority of the embryo cells are normal and chromosomally quite competent. Such an embryo is referred to as being mosaic. A mosaic embryo very often recovers once placed in the uterus because the majority of the embryo cells, or blastomeres, are normal and can recover, so that the rest of the embryo, then grows up to be normal and will propagate a healthy pregnancy. So not all embryos diagnosed as being aneuploid are permanently abnormal. A small percentage, and the younger the woman is, the higher that percentage is, will be mosaic. Now, the laboratory can very often differentiate between a mosaic and a truly aneuploid embryo. Remember, they look at about 5 or 6 cells from the advanced embryo. And if some of those cells are normal and some are abnormal, then they know it's mosaic. But it's not that reliable, because sometimes all the cells can be abnormal, but yet not represent all of the all of the cells biopsied can be aneuploid, but yet not represent all the cells in the embryo. There are 100 or more cells in a blastocyst, which is the advanced embryo that's biopsied on day 5 or 6 after fertilization. So the younger the woman, the more likely it will be that the embryo, if it's aneuploid, could be mosaic, even if it comes out as being truly aneuploid. Simply stated, the testing done in the genetics laboratory is not all-encompassing. So let's go back and again state the fact that before we can say that this cause of the failure to conceive is because the embryo is aneuploid or abnormal and it doesn't even take in many cases, we have to be sure that that is the case, so that we need to do PGT or PGS in any subsequent egg retrievals and analyses of embryos. So having said that, let's now look at a situation where a woman has embryo transfers done more than once but keeps failing without having done PGT testing. So what are those factors? Well, the first one is the woman's age. The older a woman becomes, the more likely it is that the egg she harbors will be abnormal because of a wear and tear effect on eggs that have been in her ovaries all her life. If that egg is fertilized through in-vitro fertilization, or ICSI, intracytoplasmic sperm injection, and propagates an embryo that looks normal, it is more likely to be normal if it grows to looking normal by day 5 or 6. But it doesn't mean it is. And the older the woman is, the less likely it is that a normal looking embryo will in fact be chromosomally normal. That is because in a young woman, up to about 35 years of age, 2 out of 3 eggs are normal chromosomally. And it's the egg and not the sperm that determines whether the embryo will be normal chromosomally or euploid. So it is extremely important to take into consideration of the age of the woman. Whereas a woman of 40, only 1 in 5 will likely be normal, and at 45, only 1 in 20 or less will be normal. Even though the embryo looks normal, it may still be aneuploid if it wasn't tested by PGT. Let me give you a little example. If I got an embryo that was perfect, microscopically and morphologically graded with the highest grade, and was a blastocyst that was expanded and looked gorgeous, and the woman was 32, 33 years of age, that embryo will probably have about a 2 in 3 or 3 in 4 chance of being euploid or competent and have a normal chromosomal configuration, numerically speaking. whereas the same looking embryo in a woman of 45 would only have about a 4 or 5% chance of being normal, even though it looked normal, because of the fact that you can't see the chromosomes under a regular microscope. You have to do that procedure I mentioned earlier, embryo biopsy for PGT, to know if the chromosomes of the embryo are normal. So if we get a normal looking blastocyst in a young woman, it's not usually necessary to do PGT testing in all cases, because 2 out of 3 or even 3 out of 4 times that blastocyst will be normal, and if it's normal, it'll be able to propagate a pregnancy in about 60 to 70% of cases. Whereas if a woman is in her 40s, mid-40s, with good-looking embryos, doing PGT, in my opinion, is an imperative, because it could still be abnormal by virtue of age and the wear and tear effect on her eggs that will impact the embryo. Now, I'm not saying that abnormal sperm can also not produce an aneuploid embryo. Sure it can, but it's far less likely to be the case, because the egg has the ability to be selective in choosing the best sperm that comes and attaches itself to the outer envelopment of the egg to fertilize it. So very definitely sperm is a factor, but usually not unless there is a situation of very severe male factor infertility. So when it comes to age, the appearance of the embryo alone is not good enough to make a definitive diagnosis that the embryo is in fact euploid and competent. PGT testing is very important to consider in all cases of women in their late 30s and early 40s, but of course even more so in a woman that has failed to get pregnant in spite of a number of IVF attempts, even in younger women, because then there's the possibility that there's a chromosomal abnormality repeating itself in the embryo in spite of it not needing to be that way because she's younger. Age is a factor. On the other hand, if you do PGS testing and the embryo is normal, then it largely does away with the impact of age. Because a woman of 45, even though only 1 in 20 of her embryos are likely to be normal chromosomally, if you come across an embryo that is normal, then that embryo is far more likely to be able to propagate a viable pregnancy. Rather than 4%, it may be 6 or 10 times more likely to be able to produce a viable pregnancy. This is why doing PGT testing in older women and a woman of any age who's had repeated IVF failures is so imperative. The second issue to consider is then the issue of the quality of the embryo genetically. Remember, the genes aren't the chromosomes, they're on the chromosomes. And as women get older, it's more likely for there to be genetic abnormalities. In fact, absence of or extra production of genes on the chromosomes that results in an irregular quota of irregular genetic configuration. This also tends to be more common as women get older, but not nearly as prevalent as the chromosomal abnormalities that I spoke about. Now, after we get to age, oh, by the way, there is no way that we can test the genetics on an embryo for the purpose of making sure it's competent. When, in terms of what I've just been talking about, we do genetic testing on embryos if there is a predisposition, either through previous testing of either partners, where we find that there are genetic recessive or dominant traits involving the genes, or in situations where the genetic makeup of the embryo has been previously found in a previous analysis to be abnormal. Genetic testing is not a prerequisite, and I know more and more IVF labs do testing on both partners to see if they're carriers of certain genetic abnormalities. I think that's could be a little bit of an overkill. It may be advisable if there's a family history of genetic abnormalities, or if there's a suspicion from repeated IVF failures for unexplained reasons with chromosomally normal embryos, to then go in and do genetic testing of the embryo or genetic testing of both partners. But as a routine, I think it's a bit of an overkill. The next consideration is the issue of the embryo transfer procedure that was done before. Now we're into the technical issues that can lead to IVF failures. I can't overemphasize how important the embryo transfer timing and technique is. My view is that the embryo needs to be transferred either one at a time or two at a time, and preferably in cases of prior IVF failures after the embryos have been selected by PGT or PGS. But the method and timing of the transfer is also important. It's important also to bear in mind that preparation for the transfer, and these are, if there's PGT done, there will always be frozen embryo transfers, or FET, done in a cycle where the woman's uterine lining is prepared hormonally, or in natural cycles in some cases, which I'm not much in favor of, because you can get a much finer tuning of the implantation window, the ideal time to put the embryo in, if you do it hormonally. So it's important to prepare the uterus properly. Many of you are using a technique known as ERA, the endometrial receptivity assay, where the doctor comes along in a preceding cycle, does a biopsy of the embryo and checks, a biopsy of the uterine lining or endometrium, and to look and see whether the endometrium is when it'll be most receptive for the transfer. Sounds like a great idea, and it's created a lot of interest, because after all, you can test an embryo, an endometrium, in a previous cycle by biopsying it, and then come back in a subsequent cycle and put it back, having timing more fine-tuned. Well, I'm not very much in favor, because I don't believe you can do it biopsy in 1 month and then extrapolate that that's exactly how it's going to turn out in the subsequent month. In fact, we did a study where we looked at the same women undergoing serial endometrial receptivity assays over several cycles, and we found that the receptivity window, or the window of implantation, was varying very often in the same woman from cycle to cycle. And if that's what we find in some cases, how can we rely upon it in terms of putting the timing exactly when to put the embryo in? So while there's nothing wrong with doing ERA, I'm not a big fan, and I've just given you my reasons for it. The ideal time to put an embryo in is about 6 days after the progesterone started in the woman. That's the ideal time to put the embryo back in the uterus. And again, as I say, 1, but never more than 2, because having a singleton pregnancy is the safest. Twins are not as safe for the baby or for the mother. There are problems relating to premature delivery and all kinds of things that go wrong in such situations when there's more than one baby. But it's not as serious an issue in a healthy young woman as it would be if you put back more than 2. And I would never put back more than 2 embryos at a time, for fear of what we call higher order multiples, triplets or greater, where the risks to the mother are inordinate and to the baby even worse. So it's important to keep this in mind when you are doing transfers in terms of how many embryos to put back. Now, what about preparing the uterus that can go wrong? There are many ways to prepare the uterus for a frozen embryo transfer, and all of them have merits, and a number of them have disadvantages. I'm giving you my personal opinion here based on 38 years of experience and being influential in the births of more than 17,000 babies. It's my opinion that you're best served by hormonal therapy to prepare for the transfer. Because when you do a transfer in a natural cycle, the window in which you need to put the embryo back, the timing, is much more intricate. It's only a few hours that you have, and it's harder to pinpoint that time for the transfer and be precise and do it always in the daylight hours. I don't believe that there's any advantage personally in doing natural cycle transfers. There's the other fact, and that is even a woman with natural cycles, if she goes into a frozen embryo transfer cycle, can end up with hormonal aberrations because of the stress she's under and the pressure that she's in. So I'm not for natural cycle transfers. The second, of course, is hormonal, which I prefer. But there's several ways to administer the hormones. The commonest used, and again, in my opinion, the least advantageous, is to take oral pills to prepare for the transfer. When you take something by mouth, it first gets absorbed from the gastrointestinal tract via the liver, passes through the liver where it changes and reaches the blood circulation, the systemic blood circulation, and there up on the uterus. Passing through the liver can alter the estrogen you take orally. I prefer to give it either by mouth or by skin applications as patches. Giving it, let me go back, I misspoke. Either by injection or by skin patches, not by mouth. I just said not by mouth, so I know where I'm at. But anyhow, giving it by injection is the best way to go, because you can use del-estrogen, which is estradiol valerate, and inject it twice a week. I have it injected on the Tuesday and Friday, so I have the Monday and Thursday to check the blood levels, because the blood level of estrogen or estradiol in each particular case is important. You want it to range between 500 and 1,000 picograms per milliliter, and close to 2.5 to 3 times that if you're using English, European, or Canadian measures of picomoles per liter, in order to have the ideal range of estrogen to give an ideal uterine lining. And in my opinion, that is the best way for estrogen to be administered. Again, I use estradiol valerate injections, or also known as del-estrogen, because this is easily and evenly absorbed if it's injected just under the skin. So you can get those levels and keep them sustained at a decent level. You can, of course, also have the estrogen absorbed through the skin using skin patches, and that will also go directly into the systemic circulation without first passing through the liver, because you're not swallowing it first. And that's very good. But it's harder to sustain even levels of estradiol of 500 to 1,000 in this way. There's perspiration, the patches can fall off, and you can get disparate levels of estrogen, harder to maintain at the level you want it to be. So in my practice, I try to persuade all my patients to use hormonal replacement for the frozen transfer, and to do it by injection, ideally twice weekly. That is a very good way to go, in my opinion. Now, in some women, one of the problems that you have is that they can't produce an adequate uterine lining, and I'll be talking about this in a few moments. It needs to be at least 8 millimeters in thickness. The endometrial lining needs to be on the day you start the progesterone, or a day or two before. It's no good measuring the thickness of the uterine lining after you've started giving the woman progesterone, because that will fill the glands of the endometrium with secretions and falsely thicken the lining. So you want to measure it before you give the progesterone. It needs to measure 8 millimeters or better, ideally over 9. But if it's less than 8, there are ways to treat it. You can give the woman vaginal Viagra suppositories, which works extremely well. It's something I introduced in the early 90s, and it works, the mid 90s. It works extremely well because when you insert it vaginally, it's absorbed directly into the uterus without reaching the blood circulation in high concentrations and causing side effects. and this improves blood flow to the uterus and delivers more estrogen to the uterus to thicken the lining. So many women who have thin uterine linings will have a benefit from using Viagra. In fact, only yesterday I was told about a patient of mine that had been placed on estrogen injections alone, but didn't develop an adequate lining. We continued on for 3 or 4 more days by adding vaginal Viagra, and her lining is 11 millimeters today. So there are ways to improve this problem. Giving the woman more estrogen doesn't help. It's not a question of there not being enough estrogen delivered. It's a question of it being delivered to the uterine lining. And to get it there, you have to open up the pipes, the blood vessels that carry it through the uterine wall to the lining to thicken it. So the embryo transfer procedure done is very important in the preparation for it. Then with the transfer, it should always be done with a woman undergoing an ultrasound, a vaginal ultrasound. So you can direct the catheter exactly where you want to place it. I don't personally believe in doing test transfers beforehand. I don't think it's a good idea to put catheters into the uterus repeatedly because you can introduce infection and interfere with implantation. I think you can do it just as well by doing an abdominal ultrasound, visualizing the lining, and if you've got the skill and the experience, gently place the catheter that you're passing through the cervix under direct visualization to within 1 centimeter of the cavity, but not proceeding all the way up to the top of the cavity, because you can cause a little bit of irritation, which can cause bleeding that you won't necessarily see, because you won't see any blood coming out of the uterus unless there's been about 8 milliliters of blood in the uterus, and you need not have that much to be able to interfere with the environment for implantation. So my feeling is that doing a gentle ultrasound with skill and dexterity, and doing it 36 hours after putting the embryo in exactly to the right location, and expelling the embryo 1 centimeter from the top of the uterus. I also do not believe that women should be on blood thinners like aspirin before the transfer. If you take an aspirin, even a baby aspirin a day, it'll thin the blood, and then when you put the catheter through the cervical canal under direct vision into the uterus, you can churn up the lining, cause bleeding again, and interfere with implantation. So I don't use aspirin on my patients undergoing embryo transfer. The embryo transfer is a very important step in securing a healthy pregnancy. And it can be botched if you don't time it correctly or if you don't use the proper technique. Now, the last factor that I want to mention is the issue of implantation. I'm not going to go into it in detail. It will be the subject of a much more extensive later video that I'm going to do again. Implantation means the embryo sends its roots into the wall of the uterus, what we call the trophoblast. And that trophoblast is what's going to form the placenta, which is the lifeline for the baby. I can't overemphasize how important implantation is. True, 80% of the time when there's a failure of IVF, it's not due to an implantation problem, but rather due to an embryo quality problem, which can stem from the chromosomal and or genetic integrity of the embryo. Of course, I didn't mention this today, but I will go into it in much greater detail in a separate video that will be coming soon. The method used for ovarian stimulation is critical when you try to optimize the quality of the eggs. And as I said, it's the eggs that are mostly responsible for embryo competency and whether it's going to be euploid or aneuploid. So, very important to understand that implantation refers to uterine factors that are going to be responsible for preventing the embryo to attach. And these, in my opinion, are the most commonly overlooked, even by experienced people in the field. I don't know why. I think it's a travesty, because even though it's not a common cause of IVF failure per se, if a woman repeatedly fails, you've got to at least consider that if it's not the seed or the embryo that you're transferring that's defective, that it could be the soil or the uterine lining. You can't put a good seed in a bad soil any more than you can put a bad seed in a good soil and expect a healthy plant to grow. The plant being an analogy for the embryo. So it's very important to consider that in 20% of cases of regular IVF, unbeknownst, it could be the endometrium, the uterus, that is not receptive. But if a woman's having repeated failures or miscarrying repeatedly, that 20% can be the predominant cause of the failure. In fact, it often is in such cases and needs to be looked at very, very carefully. So there are 3 factors that determine implantation. I'm just going to go over them very quickly. One is the thickness of the uterine lining, which I've alluded to earlier. The uterine lining must be at least 8 millimeters thick. And if it's ideal, it'll be over 9 millimeters with a trilaminar or 3-line appearance, like the outer perimeter of the endometrium and the inner surface where the 2 surfaces meet. And that gives a trilaminar appearance, which is sometimes not visible, especially if the uterus is tipped backward or there's been surgery done in the uterus in the past. But the thickness is by far the most important. If the lining's under 8 millimeters, there's a reason for it. We're not going to go into that in detail here. I'll discuss that in a subsequent video down the line. But it is very important to consider the possibility of using vaginal Viagra with estrogen in such cases. And the addition of a pill or a medication, we call it antiprostaglandin, in such cases can be considered, such as using something called indomethacin. But I personally am very, very wary of using this or aspirin, which is also an antiprostaglandin, because of the reasons I told you about earlier, causing bleeding in the uterus. So it's important to take this into consideration as well. The second factor in the uterus is the presence of irregularities in the cavity. If there's a little polyp or a fibroid or scarring protruding at the cavity of the uterus, it can irritate the lining and result in the embryo being rejected by cells called macrophages that rush to the area of irritation. Think of how people use an intrauterine contraceptive device, an IUD, which works by putting a foreign body into the uterus to cause an irritation that will attract macrophages and actually destroy the embryo. So women using an IUD get pregnant over and over, but they will lose the pregnancy before they even knew they're pregnant, thinking that they're contracepting. What they're really doing is inducing a very early loss. But you can have your own foreign body in the uterus if there's a fibroid or a polyp, like a little mushroom growing into the cavity. And it needn't be large. It can be as large as your little fingernail. This is the reason why everybody undergoing embryo transfer, fresh or frozen, should have their uterus inspected inside by doing a hysteroscopy or a saline ultrasound to see that the cavity is regular before doing the transfer, and rule out any surface lesion. So the regularity of the uterine cavity is got to be smooth. If it's not, it's got to be fixed, and it can be fixed surgically or by inducing a period and coming back and repeating it in the subsequent cycle to see if a small irregularity wasn't just simply an outgrowth of the endometrial lining rather than a polyp. But the best way is to go in and do DNC or a hysteroscopic resection of a fibroid or a polyp. Oftentimes, a fibroid or a polyp will be on a stem, like a mushroom, and you go in and snare the stem, snip it off, remove the polyp without trauma, and come back 4 to 6 weeks later and do another frozen transfer. But I am against, and I would strongly recommend against, ever doing an embryo transfer if there's a surface lesion in the uterus. The third factor is one I'm going to do a very significant and large video podcast on soon, and it is on the immunologic factor. Very simply, there are cells in the uterine lining of all women, immune cells, that play a very vital role in regulating the growth of the roots of the embryo into the wall of the uterus and the formation of the placenta. These cells comprise various immune cells known as lymphocytes, the most important of which is one called natural killer cells, which comprises 70% of all the immune cells in the uterine lining. These natural killer cells are vital to the survival of our species because it's believed that they release factors that regulate the growth of the roots of the embryo into the wall of the uterus. These factors are known as cytokines. Now, there are 3 varieties, but 2 are important in this regard. The one is called Th1 cytokines, such as interferon gamma and TNF-alpha, and the others are called Th2 cytokines, known as interleukin 10. Now, what happens is that the Th2 cytokines attract the roots into the wall, and the Th1 cytokines, through the release of these TNF-alpha and interferon gamma predominantly, destroy some of the roots by killing off the cells through a process we call apoptosis. It's like a self-suicide. It drives the cells into a suicide mode. The purpose is that the placenta that develops will be confined to the inner aspect of the uterine wall, and that this placenta, therefore, will come away readily after the baby's born. Were it not for this balance between Th1 and Th2, it's possible, if there was a predominance in the activity of Th2, that the root system can grow right through the wall of the uterus like a cancer, and that this could then cause major problems where the placenta won't come out after the birth of the baby. All kinds of problems can arise from this. We call it placenta accreta or placenta increta. But sometimes what happens is there's an overproduction of the Th1 cytokines, which attack the roots and kill the cells. If this is over-accentuated, then the embryo's roots will be killed before it can take a proper hold and form the infrastructure of the placenta properly. In such cases, the woman can lose the pregnancy before she ever knew she was pregnant. She'll think she's infertile, but she's really having many miscarriages so early she never knew she was pregnant in the first place. Such women will present to you like infertility, and they'll think they're failing IVF or not getting pregnant because there's something wrong with the embryos, whereas in fact this was due to an immunologic implantation dysfunction, or an IID. So it's really important to make sure that there are not natural killer cells that are overproducing Th1 cytokines. We call such natural killer cells activated. Activated natural killer cells can be measured in 2 ways. One, you can do a biopsy of the endometrium and measure the Th1 cytokines in the endometrial cells. More recently, people have tried to expand that into doing blood testing for Th1 and Th2 cytokines. These, in my opinion, are not that reliable. They're better than nothing, but they're not that reliable. So using blood cytokines is a way to measure it, but not as reliable as the gold standard, which is a test known as the K562 target cell test. The K562 test takes your blood, spins it down, it gets to the natural killer cells, which aren't necessarily of uterine origin, but they do mimic what goes on in the uterus. And then these natural killer cells are separated using a process called flow cytometry. And once we've identified these natural killer cells, we grow them in the presence of target cells, thymic cells, which react like the endometrium. And that is, if there's an overpreponderance of Th1 cytokines, they get killed. And the percentage of these cells that are killed in the laboratory give you an indication of whether there's overactivity of natural killer cells, too much Th1 activation. This test is the gold standard. I still use it preferentially. I do take cognizance of the blood Th1 cytokines, and especially of uterine cytokines if done, but there are very few people that do that test, the uterine biopsy for cytokines. But the best one, as far as I'm concerned, is the Th1 cytokines as measured from the endometrial cells or measured from the by doing the K562 blood test on the woman. If the natural killer cells are activated, we can certainly treat it by using intralipid and steroids. Now, not all natural killer cell activation is imminently reversible. Most of it is caused by autoimmune conditions. For example, women who've got endometriosis, even the mildest variety, can have activated natural killer cells, even though the concentration in the blood system may be reduced. It's the activity, not the concentration, that counts. Remember, natural killer cells are good guys. The more the merrier. We need them. But we don't want activated natural killer cells. And that's where the K562 test comes in. And women with endometriosis, even before they develop overt evidence of it, can have activated natural killer cells. It's not how severe the endometriosis is that matters. It's just the existence of it. And even women that test positive for a test we now do called the BCL6 or the receptiva test, which isn't that reliable for endometriosis detection, but it gives you a suggestion that it's present, in my opinion, should be tested for natural killer cell activation. And for other immune components, like phospholipid antibodies, those can be treated with intralipid, steroids, and heparinoids like Lovenox. But the other cause of activated natural killer cells is one that's not related to an autoimmune underpinning, such as endometriosis, lupus, rheumatoid arthritis, hypothyroidism or Hashimoto's disease, etc., but rather due to the husband and partner, male and female, sharing certain genetic similarities involving HLA or DQ alpha. When those match, the embryo will share a DQ alpha that comes from the father. And if that matches the mother's DQ alpha in her uterus, it's not a question of egg and sperm, it's a question of the embryo having the husband's DNA, his DQ alpha gene, in the embryo, and that matching the woman's body's DQ alpha. Then the embryo will match. And if the embryo matches, it will progressively over time cause increased production of Th1 cytokine, and that will reject the embryo. It doesn't happen straight away. And if a woman's got a DQ alpha genetic match with her partner from blood testing both of them, doesn't mean she's got the problem. There's got to be natural killer cell activation in addition, and that happens over time. So that it's important to test them both of them for the DQ alpha and the woman for natural killer cells, and only if it's activated, then should we go ahead and treat it. So that is an overview of the factors that can lead to a diagnosis that can be responsible for recurrent pregnancy, recurrent IVF failure, and yes, in some cases recurrent pregnancy loss. Important to rule it out. I urge you, if you failed IVF once, to be suspicious. If you failed IVF twice, to be more than suspicious, and to insist that whatever is done, that these factors get thoroughly evaluated. There are others as well, like things called balanced translocations. We're not going to go into them here because they occur in 1 in 300 pregnancies. But there are other factors as well. These are the central ones that need to be looked for. Now, I urge all of you who listen to this podcast or this video and are interested in getting my personal input as it pertains to your particular case, to call my assistant Patty Converse at 702-281-7, that's my number, 702-533-2691, 702-533-2691, or email her at concierge, concierge, at sherivf.com. She will then arrange for you to have an online consultation with me to discuss your case in detail, and I'll try to be of some constructive help to you. I look forward to the possibility of being of service, and I thank you very much for listening to this podcast.